PHSNC Peer Support Service Definition Training, NC Medicaid Clinical Coverage Policy 8G, 3-hour staff training, helping you live your dreams every day. Welcome to PHILA Health Systems of NC's Peer Support Services Training. This 3-hour training is designed to help staff understand and apply NC Medicaid Clinical Coverage Policy 8G while delivering services in a way that reflects the mission, vision, values, and person-centered standard of PHSNC. At PHSNC, compliance is the floor. Our mission, our values, and our hero statement define how we show up for the people we serve, helping you live your dreams every day. Before we discuss the Medicaid rules, we begin with the foundation of PHSNC. Peer support services are not simply contacts, visits, conversations, or transportation. Peer support services are structured, recovery-oriented interventions designed to help people build skills, strengthen independence, connect to community resources, and move toward meaningful recovery goals. PHSNC's mission is to provide person-centered, compassionate, clinically sound services that empower individuals and families to achieve stability, independence, sustainable recovery, and meaningful quality of life. Our vision is to create equitable access to integrated, culturally responsive care that reduces barriers, prevents unnecessary institutionalization, and strengthens community supports. Every peer support contact should reflect the PHSNC hero statement, helping you live your dreams every day. At PHSNC, our values are more than words. They are practice standards. Purpose means every intervention connects to a documented need, a person-centered plan goal, and the person's recovery priorities. Heart means we lead with dignity, compassion, cultural humility, and belief in every person's capacity to recover. Impact means we document progress and measure whether services are helping the person function better. Leadership means we model recovery, ethical practice, accountability, and responsible stewardship of Medicaid services. Advocacy means we help people use their voice, understand their rights, access resources, and navigate systems without creating dependency. Module 1, Service Model and Recovery Framework. NC Medicaid Policy 8G defines peer support services as a community-based, evidence-based mental health model of care for eligible adults with mental health or substance use diagnoses. Services are provided by certified peer support specialists who self-identify as persons in recovery. The power of peer support is rooted in mutuality, lived experience, hope, and the belief that people can recover, grow, and participate meaningfully in community life. Peer support services may be delivered alongside other approved services or as an independent service when criteria are met. However, peer support must always be purposeful, structured, documented, and connected to the beneficiary's assessed needs and person-centered plan. Let us go deeper into what recovery-oriented practice means at PHSNC. Recovery is not simply the absence of symptoms. Recovery is a personal, self-directed process of growth, change, and engagement in a meaningful life. People in recovery define what a meaningful life means for them. The role of the certified peer support specialist is to walk alongside that process, not to lead it. The recovery framework that guides peer support services is grounded in several key principles. First, recovery is possible for everyone. This is not a belief we hold only for those who have already made visible progress. This is a belief we hold for every person we serve, on every difficult day. Second, recovery is self-directed. The person sets the goals, the pace, and the priorities. The certified peer support specialist supports those goals, not the other way around. Third, recovery is holistic. It addresses not just mental health or substance use symptoms, but also housing, employment, relationships, physical health, spirituality, culture, and community. Fourth, recovery is supported by peers. The lived experience of the certified peer support specialist is not a credential to display. It is a tool to use carefully, ethically, and in service of the person's own journey. Sharing lived experience should never dominate a session. It should open a door, build trust, and demonstrate hope. Fifth, recovery is culturally grounded. PHSNC staff must approach every person with cultural humility. This means recognizing that culture, language, identity, and community shape how people experience distress, define recovery, and seek help. Effective peer support honors those differences rather than minimizing them. Sixth, recovery reduces stigma and builds belonging. One of the most powerful things a certified peer support specialist can offer is the lived proof that recovery is real. Being present in the community, living a life of purpose, and modeling accountability reduces the shame that keeps many people from seeking or sustaining help. At PHSNC, the service model also recognizes the difference between support and enablement. Support means helping someone build their own capacity. Enablement means doing things for someone that remove their opportunity to grow. When a certified peer support specialist drives someone to an appointment without helping them practice self-advocacy, that is enablement. When a certified peer support specialist helps someone prepare questions for their provider, practice how to express their needs, and process how the appointment went, that is peer support. PHSNC staff should ask themselves a simple question before and during every service contact. Is what I am doing right now helping this person become more capable, more confident, or more connected? If the answer is no, the activity may not meet the standard of billable peer support. Peer support services, under Policy 8G, are also specifically distinguished from other behavioral health services. Peer support is not psychotherapy. It is not medication management. It is not case management. It is not personal care. It is not crisis intervention, although a certified peer support specialist must know how to recognize a crisis and respond according to PHSNC procedures. Peer support is a distinct service delivered by a person with lived experience, credentialed as a certified peer support specialist who uses that experience within an ethical framework to promote recovery. Because peer support is delivered in the community, the certified peer support specialist operates with more independence than many other direct service roles. This makes ethical grounding, strong supervision, and reliable documentation more critical, not less. PHSNC supervisors must ensure that each certified peer support specialist on their team understands the scope of their role, stays within that scope, and documents every intervention clearly and accurately. Peer support is not casual support. It is not simply spending time with someone. It is not transportation. It is not supervision. It is not doing things for the person that the person can be supported to learn, practice, or do for themselves. At PHSNC, peer support should help the person move one practical step closer to stability, dignity, independence, and community connection. Crisis recognition and response is one of the most important competencies for a certified peer support specialist to develop. While the specialist is not a crisis clinician and should not attempt to manage psychiatric emergencies independently, they are often one of the first people a beneficiary reaches out to when distress escalates. Knowing how to respond can be life-saving. Crisis recognition begins with knowing the person. The certified peer support specialist who has built a strong, trusting relationship with a beneficiary is better positioned to notice when something is off. A change in communication pattern, a missed appointment, an unusual tone in a message, or a comment that seems out of character can all be early warning signs. Specialists should take these signals seriously and check in directly rather than assuming everything is fine. When a beneficiary expresses thoughts of suicide or self-harm, the certified peer support specialist must follow PHSNC's crisis response protocol immediately. This protocol will specify what actions to take, who to notify, and how to document the contact. Specialists must know this protocol before a crisis occurs, not in the moment when a person is in distress. If you do not know PHSNC's crisis response protocol, ask your supervisor today. The role of the certified peer support specialist in a crisis is to remain calm, stay present, listen without judgment, help the person access their safety planning tools, and connect them to appropriate crisis resources. It is not to promise to keep secrets, to attempt clinical interventions outside their scope, or to manage the crisis alone. The specialist should involve their supervisor as quickly as possible and should document everything that occurred. After a crisis contact, the certified peer support specialist should debrief with their supervisor. The debrief should address what happened, how the specialist responded, what went well, and what could be improved. It should also address the specialist's own emotional response to the situation, because crisis contacts can be distressing for the helper as well as the person in crisis. Motivational approaches are a cornerstone of effective peer support practice. Motivational interviewing is a clinical skill that certified peer support specialists can learn and adapt within their scope of practice. The core spirit of motivational interviewing, which includes partnership, acceptance, compassion, and evocation, aligns closely with recovery-oriented peer support values. In practice, using a motivational approach means asking open-ended questions that invite the person to explore their own thoughts and feelings. It means reflecting what you hear in a way that helps the person hear themselves more clearly. It means affirming the person's strengths and past efforts. It means summarizing what has been discussed in a way that draws out ambivalence and identifies the person's own reasons for change. A motivational approach is especially useful when a beneficiary is ambivalent about recovery goals, resistant to engaging with services, or caught between competing priorities. Rather than confronting the ambivalence directly or trying to argue the person into change, a motivational approach invites the person to explore both sides of their ambivalence and to identify their own motivation for moving forward. Certified peer support specialists who develop motivational skills do not need to be formally trained in motivational interviewing as a clinical protocol. What matters is the spirit of the approach: genuine curiosity, non-judgment, and deep respect for the person's autonomy and capacity to direct their own recovery. The Wellness Recovery Action Plan, commonly known as WRAP, is a structured self-management tool developed by Mary Ellen Copeland that has become widely used in recovery-oriented behavioral health services. WRAP helps individuals identify their personal wellness resources, develop daily maintenance plans, recognize early warning signs of distress, create crisis plans, and identify post-crisis recovery steps. For certified peer support specialists, introducing WRAP to a beneficiary is a concrete, documented, skill-building activity that connects directly to person-centered plan goals. Supporting a person in developing their WRAP plan over a series of contacts provides structure, continuity, and a tangible product that the person can use independently. Reviewing and updating the WRAP plan as the person progresses is also a meaningful service activity. WRAP is not a clinical treatment, it is a self-directed tool. The certified peer support specialist does not complete the WRAP plan for the person. They support the person in completing it themselves. The specialist may share from their own experience with wellness planning, offer examples of how other people in recovery have used similar tools, and help the person think through the different sections. But the content of the WRAP belongs to the individual. Other evidence-based recovery tools that certified peer support specialists can introduce and support include strengths inventories, recovery capital assessments, peer support mapping exercises, and personal goal-setting frameworks. Supervisors should help their team members build familiarity with these tools and integrate them into regular service contacts. Now let us explore the ethical use of lived experience in greater depth, because this is one of the most important and nuanced aspects of the certified peer support specialist role. Lived experience is not just a qualification, it is an ethical responsibility. When a certified peer support specialist chooses to share their own story, that disclosure must always serve the beneficiary, never the staff member. Self-disclosure should be brief, purposeful, and relevant to what the person is experiencing. It should open a door, not redirect the conversation to the specialist's own journey. For example, if a beneficiary is struggling with shame about their diagnosis, a brief disclosure such as, "I understand what it feels like to be afraid of what people would think, and I found a way through that," can be powerful. But spending 20 minutes telling your own recovery story while the beneficiary listens is not peer support. It is the wrong use of the role. The NC Peer Support Specialist Code of Ethics provides clear guidance on self-disclosure. Staff should review this code regularly and discuss it with their supervisor. If you are unsure whether a self-disclosure was appropriate, bring it to supervision. This is not a punitive conversation. It is a reflective practice that strengthens your work. Boundaries are another critical ethical topic. Certified peer support specialists must maintain clear professional boundaries in all aspects of their work. Boundaries protect both the beneficiary and the staff member. Common boundary challenges in peer support include beneficiaries who want to develop a personal friendship with the specialist, beneficiaries who contact the specialist outside of scheduled service hours, situations where the specialist feels personally triggered by the beneficiary's circumstances, and situations where the specialist wants to give gifts or receive gifts from the beneficiary. None of these situations are simple, and they are not signs of failure. They are signs that meaningful human connection is happening. The key is how they are managed. When a boundary challenge arises, the certified peer support specialist should bring it to their supervisor promptly before making any unilateral decisions. The supervisor can help the specialist respond in a way that protects the beneficiary, maintains the integrity of the professional relationship, and supports the specialist's own well-being. Well-being for the certified peer support specialist is not a luxury, it is a clinical necessity. Peer support work is emotionally demanding. Specialists regularly encounter stories of suffering, loss, and struggle that may resonate deeply with their own histories. Without adequate self-care, supervision, and organizational support, even the most capable certified peer support specialist can experience compassion fatigue, vicarious trauma, or relapse risk. PHSNC is committed to creating a work environment where certified peer support specialists are supported in their own recovery and well-being. This means providing meaningful supervision, access to employee assistance resources, reasonable caseload sizes, and a culture where asking for help is encouraged rather than stigmatized. If you are struggling, tell your supervisor. If a beneficiary situation is affecting you, bring it to supervision. Your well-being is not separate from your effectiveness. It is the foundation of it. Recovery tools are another important area for certified peer support specialists to develop proficiency in. A recovery tool is any structured technique, resource, or practice that supports a person's recovery journey. Examples include the Wellness Recovery Action Plan, also known as WRAP, which is a self-directed tool that helps people identify their wellness needs, daily maintenance activities, early warning signs of distress, and crisis plans. The certified peer support specialist can introduce WRAP to beneficiaries, support them in developing their plan, and use the plan as a reference during service contacts. Other recovery tools include strength-based inventories that help people identify their capacities and resources, peer support mapping tools that help people identify their natural support networks, goal-setting frameworks that help people articulate their priorities and track progress, and mindfulness and wellness practices that support stress management and emotional regulation. Certified peer support specialists should continuously expand their toolkit. Supervision, continuing education, peer specialist networks, and self-directed learning all contribute to the specialist's ability to offer a rich, varied menu of recovery-oriented interventions tailored to each person's goals and preferences. We want to spend additional time now reviewing practical scenarios that illustrate the difference between strong and weak peer support practice. These scenarios are designed to help you apply what you have learned to real situations you may encounter in your work. Scenario 1. A certified peer support specialist meets with a beneficiary named Marcus once a week. Marcus has a goal in his person-centered plan related to finding employment. Each week, the certified peer support specialist picks Marcus up, drives him around, and they chat about his life. The specialist occasionally mentions job search websites. No skill is practiced. No plan is written. No resource connection is facilitated. Nothing is documented beyond met with client, provided encouragement. Is this strong peer support practice? No. The contact may feel supportive and kind, but it does not meet the standard for a billable peer support service. There is no structured intervention, no documented skill building, and no clear connection to the person-centered plan goal. Now consider a stronger version of the same situation. The certified peer support specialist meets with Marcus at the public library. Before the meeting, the specialist reviews Marcus's person-centered plan employment goal. During the meeting, the specialist uses peer coaching to help Marcus identify 3 transferable skills from his previous work experience. Together, they practice how Marcus would describe those skills in a job interview. They identify one barrier, which is Marcus's anxiety about phone calls, and they develop a strategy for managing that anxiety. The specialist helps Marcus complete an online application for a job readiness program. At the end of the session, Marcus identifies his next step. The specialist documents the intervention, Marcus's active participation, the strategy they developed, and the progress toward his person-centered plan employment goal. This is strong peer support practice. Scenario 2. A beneficiary named Simone has been receiving peer support for 6 months. Her person-centered plan goals were set at intake and have not been updated. She has achieved 2 of the 3 goals, but no one has updated the plan. The certified peer support specialist continues to provide services and document notes that reference the original goals, even though one of them is no longer relevant. Is this appropriate? No. When goals are achieved or become irrelevant, the person-centered plan must be updated. Services must be connected to current documented clinical need. The supervisor in this situation should initiate a plan review and ensure that Simone's active goals are clearly documented before additional services are billed. Policy 8G applies to eligible beneficiaries age 18 and older who meet clinical criteria. For beneficiaries under age 21, EPSDT may allow exceptions to policy limitations when medically necessary to correct or ameliorate a physical or mental condition. However, EPSDT does not require unsafe, ineffective, experimental, investigational, or non-medical services. Let us look more closely at what Medicaid eligibility verification requires in practice. Eligibility is not a one-time check performed at intake and assumed to remain in place indefinitely. NC Medicaid eligibility can change. A person may lose Medicaid coverage due to a change in income, household size, immigration status, failure to complete an annual renewal, or other administrative reasons. Staff must verify eligibility every single time a service is rendered. If eligibility cannot be confirmed on a given date of service, the service should not be billed for that date. Eligibility verification can be performed through the NC Medicaid web portal, through your organization's eligibility verification system, or through the Managed Care Organization's portal, depending on the beneficiary's plan. PHSNC staff should know exactly which system to use and should have the process documented in their workflow. If you are unsure how to verify eligibility, ask your supervisor before providing services. Now let us examine the diagnostic criteria more carefully. Policy 8G requires that the beneficiary have a mental health or substance use diagnosis, as defined by the current edition of the Diagnostic and Statistical Manual of Mental Disorders, which is the DSM-5 or later. This means the diagnosis must come from a licensed clinician who has performed a clinical assessment. A self-reported diagnosis, a family member's description, or a previous diagnosis from another state or provider does not automatically qualify the person for services. A current, documented diagnosis from a qualified clinician in the person's clinical record is required. For substance use disorders, the beneficiary must also meet ASAM Level 1 criteria, which is outpatient treatment. This means the person's substance use condition must be assessed as appropriate for outpatient community support, not requiring residential or intensive structured treatment. ASAM stands for the American Society of Addiction Medicine. Understanding ASAM levels helps peer support specialists recognize the clinical context of the person's recovery and communicate appropriately with supervisors and treating clinicians. A sole diagnosis of intellectual or developmental disability does not qualify a beneficiary for NC Medicaid peer support services under Policy 8G. However, a person who has both an intellectual or developmental disability diagnosis and a qualifying mental health or substance use diagnosis may be eligible if all other criteria are met. When in doubt about whether a co-occurring diagnosis qualifies, consult your supervisor or clinical team before proceeding. To meet specific coverage criteria, the beneficiary must have a mental health or substance use diagnosis as defined by the DSM-5 or later editions. A sole diagnosis of intellectual or developmental disability is not sufficient for Medicaid-funded peer support services. For a substance use diagnosis, the beneficiary must meet ASAM Level 1 criteria. The assessment must also show that no equally or more effective alternative intervention is supported by community practice standards, and the person must have at least one qualifying need related to the diagnosis. Qualifying need areas include needing skills to manage symptoms and use community resources, needing self-advocacy skills and reduce dependency, needing support preparing for work experience, needing peer modeling to take responsibility for recovery, and needing support developing or maintaining daily living skills. Now let us spend more time on the person-centered plan, because this document is the foundation of every billable peer support service. The person-centered plan, also called the PCP, is a comprehensive, individualized plan developed collaboratively with the beneficiary and their support team. It documents the person's strengths, needs, goals, preferences, and the services and supports that will help them achieve their recovery goals. The person-centered plan must be completed by a qualified professional. It should reflect the person's own voice, priorities, and goals. It should not read as if the clinician wrote it without the person's input. Person-centered language means using the individual's own words where possible, describing goals in terms of what the person wants to achieve rather than what clinical staff want them to do, and treating the person as the expert on their own life. For peer support services, the person-centered plan must include at least one goal that peer support is designed to address. The goal should be specific enough that the certified peer support specialist can design structured interventions around it. Vague goals like improve mental health or stay stable are not sufficient. A strong PCP goal might say something like, the individual will practice 2 relapse prevention strategies when experiencing stress, with support from the certified peer support specialist over the next 90 days. The person-centered plan must also include a crisis plan. The crisis plan identifies warning signs of crisis, the person's preferred responses, emergency contacts, preferred providers, and steps the support team should take in a crisis. The certified peer support specialist should be familiar with the crisis plan and should know their specific role within it. They should not be expected to manage a psychiatric crisis independently, but they should know how to recognize warning signs and connect the person to appropriate resources. Person-centered plans must be reviewed and updated at regular intervals. When the plan is updated, the certified peer support specialist should be involved in the review process and should ensure that their services continue to align with the updated goals. If a person achieves a goal and no new peer support goal is added, there may no longer be a basis for continuing the service. Staff must communicate these updates to their supervisors promptly. The discharge and transition section of the person-centered plan is also important. From the beginning of services, the plan should describe what success looks like and what conditions would indicate that the person no longer needs peer support at the current level. This is not about ending services prematurely. It is about planning for the person's growing independence and avoiding unnecessary service dependency. At PHSNC, we refer to this connection as the golden thread. The golden thread means that the assessment, person-centered plan, service order, intervention, and service note must all connect. The clinical assessment demonstrates medical necessity. The person-centered plan identifies recovery goals, interventions, crisis planning, and discharge or transition needs. The service order authorizes the service. The peer support intervention must match the person-centered plan. The note must document the purpose, intervention, duration, response, effectiveness, and progress. Managed care organizations, also called MCOs, play a central role in the delivery and oversight of NC Medicaid behavioral health services. PHSNC staff must understand how the MCO system works and what specific requirements their contracted MCO imposes, because MCO requirements may be more stringent than the baseline established in Policy 8G. NC Medicaid has moved substantially to a managed care model in which most Medicaid beneficiaries are enrolled in a PHP, which stands for Prepaid Health Plan, PIHP, which stands for Prepaid Inpatient Health Plan. These plans contract with providers like PHSNC to deliver behavioral health services and are responsible for authorizing services, managing utilization, and ensuring quality. The MCO's specific requirements for prior authorization, service limits, documentation standards, billing timelines, and appeals processes are contained in the provider manual and contract. PHSNC staff must be familiar with the requirements of the MCOs that cover the people they serve. If your agency serves beneficiaries enrolled in multiple MCOs, you may encounter different requirements for different beneficiaries. This complexity makes careful intake screening, authorization tracking, and supervisor communication essential. Prior authorization is an important MCO requirement that affects when services can begin and how long they can continue. Many MCOs require prior authorization before peer support services can be initiated. The authorization must be in place before the first billable service contact. Authorization typically covers a defined period, such as 90 days or 6 months, and must be renewed before it expires. If services are provided after an authorization has expired and before a renewal is in place, the claim will be denied. When a prior authorization request is submitted, it must be supported by adequate clinical documentation. This typically includes the assessment, the person-centered plan, the diagnosis, the qualifying need areas, and the clinical rationale for peer support. A well-prepared prior authorization request reduces the likelihood of denial or delay. If an authorization is denied, PHSNC has the right to appeal. Appeals must be submitted within the timeframe specified by the MCO. The appeal should include additional clinical documentation that addresses the basis for the denial. If the denial is based on a determination that the service is not medically necessary, the appeal should include a detailed clinical argument for why the service meets medical necessity criteria for this specific individual. Now let us address consent and confidentiality in depth, because these are foundational ethical and legal obligations in peer support services. Informed consent for peer support services must be obtained before services begin. Informed consent means the beneficiary understands what services are being offered, what the services involve, the risks and benefits, their right to refuse or withdraw consent at any time, and how their information will be used and protected. Consent must be documented in the clinical record. A consent form signed at intake does not replace ongoing conversations about consent as services evolve. For beneficiaries under 18, parental or guardian consent is typically required, with some exceptions for minors who can consent independently under state law. PHSNC staff should know the rules governing minor consent in North Carolina and should consult their supervisor whenever a question arises. Confidentiality protects the person's information from being disclosed without consent. HIPAA, the Health Insurance Portability and Accountability Act, establishes federal standards for the protection of health information. NC Medicaid and PHSNC policies add additional protections. Together, these rules require that client information be shared only with those who have a legitimate need to know and only with appropriate authorization. Substance use disorder treatment records are subject to especially strict federal confidentiality protections under 42 CFR Part 2. These records may not be disclosed without the client's written consent, except in very limited circumstances, such as a medical emergency. PHSNC staff who work with individuals with substance use disorders must understand these protections and follow them rigorously. A violation of 42 CFR Part 2 is a federal offense. In practice, confidentiality means that certified peer support specialists should not discuss a beneficiary's situation in public places, should not leave documentation visible to unauthorized people, should not discuss one beneficiary's information with another beneficiary, and should not share information with family members without the beneficiary's written authorization. Even well-intentioned disclosures, such as telling a parent how their adult child is doing without the adult's consent, are violations. Releases of information allow PHSNC to coordinate care with other providers. A properly completed release must identify who the information is being shared with, what information may be shared, the purpose of the disclosure, and the expiration of the release. Releases must be signed by the beneficiary and should be reviewed and renewed as needed. When a release expires, information sharing must stop until a new release is obtained. Let us now examine the EPSDT provision in greater detail because it is frequently misunderstood by both clinical and administrative staff. EPSDT stands for Early and Periodic Screening, Diagnostic, and Treatment. It is a federal Medicaid mandate that applies to beneficiaries under the age of 21 enrolled in Medicaid. The purpose of EPSDT is to ensure that children and young adults receive the full range of services necessary to correct or ameliorate physical and mental health conditions, even when those services are not otherwise covered under the state's Medicaid plan. In the context of peer support services, EPSDT means that a beneficiary under 21 who does not meet all the standard criteria under Policy 8G may still be eligible for peer support if it is medically necessary to correct or ameliorate a physical or mental condition. For example, if a 17-year-old beneficiary has a qualifying mental health diagnosis but does not meet one of the other specific coverage criteria, EPSDT may allow coverage if the treating clinician determines that peer support is medically necessary for that individual. However, EPSDT does not authorize services that are unsafe, experimental, ineffective, or non-medical. It does not override professional judgment or clinical evidence. It does not mean that any service a young person might benefit from must be covered. It means that Medicaid coverage should not be a barrier to medically necessary services for children and young adults when a qualified clinician has determined those services are needed. When EPSDT is being applied to authorize peer support for a beneficiary under 21, the clinical documentation must clearly reflect the medical necessity determination, the specific condition being corrected or ameliorated, and the clinical rationale for peer support as the appropriate intervention. This documentation must be completed by a qualified clinician, not by the certified peer support specialist. PHSNC supervisors should involve the clinical team whenever EPSDT is being considered as the basis for service authorization. Now let us discuss the assessment process in greater depth. The clinical assessment is the document that establishes medical necessity for peer support services. It must be conducted by a qualified professional and must be thorough enough to support the diagnostic conclusions, identify the person's strengths and needs, document qualifying need areas, and justify the selection of peer support as an appropriate intervention. A strong assessment goes beyond listing diagnoses. It describes the functional impact of the diagnosis on the person's daily life. It addresses how the condition affects their ability to work, maintain relationships, manage daily living activities, engage in the community, and participate in their own recovery. This functional picture is what connects the diagnosis to the specific need for peer support. The assessment must also document the absence of equally or more effective alternatives. This does not mean that staff must prove that peer support is the only possible intervention. It means that the clinical team must consider the range of available options and document why peer support is appropriate for this individual at this time. This is a clinical judgment, not a bureaucratic checklist. Assessments should be updated when the person's condition, needs, or goals change significantly. An assessment that is years old and no longer reflects the person's current situation does not adequately support continued service authorization. PHSNC supervisors should track assessment dates and ensure that updates are completed on schedule. The qualifying need areas identified in Policy 8G each deserve specific attention in the assessment. If the assessed need is skill development related to symptom management and community resource use, the assessment should describe specifically what skills are lacking and why peer support is the appropriate vehicle for building them. If the need is self-advocacy and reduced dependency on professional supports, the assessment should describe the current level of dependency and what recovery outcomes would indicate successful progress. Each qualifying need area has its own clinical logic, and the assessment should reflect that logic clearly. We also want to address the relationship between peer support and other services in the behavioral health system. Many beneficiaries who receive peer support are also receiving other services, such as outpatient therapy, psychiatric medication management, community support, or case management. Peer support is designed to complement these services, not to duplicate them. The certified peer support specialist is not the therapist. They should not provide therapeutic interventions or attempt to process trauma with the beneficiary. They may support the person in attending therapy, completing therapy homework, or applying coping skills the therapist has taught. But the clinical relationship belongs to the therapist, and the certified peer support specialist must respect that boundary. The certified peer support specialist is not the case manager. They may help the person navigate a resource or complete a referral, but they should not take over the coordination functions that belong to the case manager. Good communication between the peer support specialist and the case manager, with appropriate releases of information, helps ensure that services are coordinated and non-duplicative. When services overlap in time, only one service can be billed. If a beneficiary is attending a therapy session and a certified peer support specialist is waiting in the lobby, the waiting time cannot be billed as peer support. If a case manager and a certified peer support specialist both meet with the beneficiary at the same appointment, only one service may be billed for that time. PHSNC staff must coordinate their schedules and document clearly to avoid overlapping service claims. Let us now go deeper into each covered service category and what it looks like in practice. Peer mentoring and coaching is the most direct expression of lived experience in peer support. When a certified peer support specialist sits with a person and shares how they navigated a similar challenge, they are not just telling a story. They are demonstrating that the path forward is real. Good peer mentoring is structured. It begins with a clear purpose tied to the person-centered plan, moves through a specific activity or conversation, and ends with the person having something concrete to take away, whether that is a new perspective, a practiced skill, a written plan, or a next step they feel ready to take. Coaching within peer support means helping the person identify barriers, explore options, practice communication skills, and build the confidence to act. A certified peer support specialist might coach a person on how to talk to their landlord, how to navigate a benefits system, how to prepare for a job interview, or how to manage conflict with a family member. These are not therapy conversations. They are practical, recovery-focused, skill-building interactions grounded in the person's own goals. Resource connection is a core peer support activity that goes beyond simply providing a list of phone numbers. True resource connection means helping the person understand what a resource can offer, supporting them to make the call or fill out the application, going with them to an initial appointment if needed, helping them process what happened afterward, and following up to ensure the connection was successful. The certified peer support specialist should maintain working knowledge of community resources, including housing programs, food pantries, employment services, transportation assistance, peer-run organizations, faith communities, legal aid, and other supports that help people stabilize and thrive. Skill-building groups are a particularly valuable format for peer support because they create community, reduce isolation, and allow people to learn from each other's experiences, as well as from the certified peer support specialist. Groups may focus on topics such as budgeting and financial literacy, job readiness and workplace communication, relapse prevention and coping strategies, conflict resolution, communication skills, self-advocacy and rights education, and wellness planning. Each group session must be purposeful, structured, connected to the person-centered plans of the participating members, and documented for each participant individually. Building community is perhaps the most hope-filled category of peer support activity. People in recovery often experience profound social isolation. They may have lost relationships due to their illness or substance use. They may feel unwelcome in community spaces. They may lack the social skills or confidence to build new connections. The certified peer support specialist can help by introducing the person to community groups, faith communities, hobby clubs, recovery communities, volunteer opportunities, and other settings where they can experience belonging and practice the skills they are building in peer support. Policy 8G identifies structured service categories that should be reflected in the person-centered plan and documentation. These include peer mentoring or coaching, resource connection, skill-building recovery groups, and building community. Peer mentoring and coaching may include encouragement, motivation, recovery action planning, problem solving, and helping the person practice recovery skills. Resource connection means helping the beneficiary connect to professional and non-professional community resources that support recovery. Skill-building groups may focus on budgeting, job readiness, relapse prevention, conflict resolution, communication, and similar recovery-related skills. Building community means helping the person develop supportive social networks, experience acceptance and belonging, and practice newly learned skills in community settings. Let us talk about place of service in more detail. Peer support services are designed to be community-based. This means they happen where the person lives, works, worships, shops, receives services, and builds their life. The person's residence is a covered place of service. Community settings such as parks, libraries, community centers, grocery stores, employment offices, and other public locations are covered. The provider's office is a covered place of service when appropriate. The emergency department is a covered place of service, and peer support there can be particularly powerful for people who are in a moment of crisis and may be open to connecting with support. Certified peer support specialists may not provide peer support in their own private residence. This is both a safety and a boundary requirement. Maintaining clear professional boundaries protects both the beneficiary and the staff member. Telehealth and telephonic services deserve special attention because they represent an important access tool, but they also carry strict requirements. Telehealth, using interactive audio and video, may be used when the beneficiary consents, when two identifiers are verified, when confidentiality can be protected, and when the service is clinically appropriate for a remote format. The GT modifier must be appended to the billing code when audiovisual telehealth is used. Telephonic audio-only services may be used when the beneficiary does not have reliable video access, but these also require consent documentation, two identifier verification, and the KX modifier on the billing code. Together, telehealth and telephonic services cannot exceed 20% of the total peer support service time per beneficiary per fiscal year. This is a hard limit. Staff must track their usage and ensure they do not exceed it. When using telehealth or telephonic services, the certified peer support specialist must document all required elements just as they would for an in-person service. The note must reflect that telehealth was used, include the modality, confirm consent was obtained, and document everything else required in a standard service note. There is no reduced documentation standard for remote services. Peer support services may occur in the person's residence, community, emergency department, or office. Services may not occur in a staff person's residence. Telehealth and telephonic audio-only services may be used when allowed, but they are supplemental and limited. Telehealth requires interactive audio and video. Telephonic services require audio-only communication and must include appropriate safeguards. Telehealth and telephonic services require documented consent, verification of two identifiers, and protection of confidentiality. The GT modifier is required for audio-visual telehealth. The KX modifier is required for telephonic audio-only services. Telehealth and telephonic combined may not exceed 20% of total service time per beneficiary per fiscal year. Employment support is one of the most impactful areas in which peer support services can help a person build independence and community connection. Research consistently shows that meaningful employment is associated with improved mental health outcomes, greater sense of purpose, reduced substance use, and stronger community belonging. For many people in recovery, the ability to work represents a milestone that affirms their progress and their identity beyond their diagnosis. The certified peer support specialist can support employment goals in many ways that are clearly within the scope of peer support. They can help the person identify their transferable skills and articulate them clearly. They can support the person in practicing job application processes, writing cover letters, and preparing for interviews. They can help the person navigate employment support services, such as vocational rehabilitation, which is a state program that helps people with disabilities prepare for and obtain employment. They can support the person in managing anxiety or other challenges related to the job search process. And they can help the person think through how employment will interact with their benefits, which is a critically important consideration for people receiving Medicaid and other disability benefits. Benefits counseling is a specialized area, and the certified peer support specialist should be careful not to provide advice about benefits rules that they are not qualified to give. However, they can help the person connect to benefits counselors and work incentive planning and assistance programs that are specifically designed to help beneficiaries understand how working will affect their Medicaid, Social Security, disability, and other benefits. These connections can be life-changing for people who want to work but are afraid of losing the supports they depend on. Housing is another area where peer support can make a profound difference. Stable housing is foundational to recovery. Without a safe place to sleep, store medications, maintain routines, and feel secure, almost every other recovery goal becomes harder to achieve. The certified peer support specialist should understand the housing resources available in their community, including emergency shelters, transitional housing programs, affordable housing waitlists, rental assistance programs, supported housing programs, and housing programs specifically designed for people in recovery. When a beneficiary is facing housing instability or homelessness, this should be treated as a clinical priority and communicated to the supervisor and care team. Housing instability is a significant risk factor for relapse, crisis, and hospitalization. Rapid connection to housing resources, coordination with case managers and community partners, and consistent support from the certified peer support specialist can make the difference between a person maintaining their recovery trajectory and experiencing a serious setback. Financial literacy is a skill area where peer support can have lasting impact. Many people in recovery have experienced financial disruption due to their illness or substance use. They may have accumulated debt, damaged their credit, or lost the practical skills needed to manage a household budget. The certified peer support specialist can support the development of financial literacy skills in concrete, practical ways. A skill-building contact focused on financial literacy might involve sitting with the beneficiary to create a simple monthly budget, reviewing a bank statement together to identify spending patterns, practicing how to communicate with a creditor about a payment plan, or exploring free community resources such as credit counseling services. These activities are clearly skill-building, clearly connected to recovery goals related to independence and daily living, and clearly within the scope of peer support when connected to the person-centered plan. Let us now walk through an extended scenario that illustrates employment and housing support in peer support practice. Meet Tamra. Tamra is a 26-year-old woman with a diagnosis of major depressive disorder and cannabis use disorder. She has been in recovery for 8 months, is living in a transitional housing program, and wants to move into her own apartment within 6 months. She has not worked in 2 years and wants to return to work as a nursing assistant, a role she held before her illness intensified. Tamra's person-centered plan includes goals related to employment readiness and housing stability. Her certified peer support specialist supports her by connecting her to the vocational rehabilitation office, practicing job application skills, helping her prepare for a benefits counseling appointment, and supporting her in creating a monthly savings plan. Each contact is documented with specific interventions, Tamra's response, and her progress toward her goals. Over 4 months, Tamra completes a vocational rehabilitation assessment, updates her nursing assistant certification, applies for 5 positions, and accepts a part-time job at a community health clinic. She also moves into her own studio apartment. Her person-centered plan is updated to reflect her achievements and to set new goals related to managing work-life balance and maintaining her recovery while employed. This is the kind of transformational outcome that well-delivered peer support makes possible. And it begins with a certified peer support specialist who shows up with purpose, uses their skills deliberately, documents their work thoroughly, and believes without reservation in the person's capacity to achieve their goals. Let us now focus on group facilitation in depth, because skill-building groups are one of the most powerful and efficient formats for delivering peer support services. And they require specific preparation and skill from the certified peer support specialist who facilitates them. A well-facilitated peer support group creates a shared experience of recovery. Group members learn not only from the facilitator, but from each other. They see their own experiences reflected in others. They practice skills in a supported social environment. They build community and reduce isolation. When groups work well, they can catalyze recovery progress that individual contacts alone may not achieve. But groups require significant preparation. The facilitator must have a clear session plan that identifies the topic, the learning objectives, the activities, and the connection to each participant's person-centered plan goals. The facilitator must be prepared to manage group dynamics, including conflict between members, domination by one person, silence from others, and emotional disclosures that require careful navigation. Group size under Policy 8G is limited to a maximum of 12 participants per certified peer support specialist facilitator. This is a ceiling, not a target. Effective groups may be smaller. A group of 5 engaged participants can be more therapeutic than a group of 12 who are not meaningfully connected. The facilitator should consider the needs and dynamics of the specific members when determining appropriate group size. Documentation for groups requires individual notes for each participant. A single group note does not meet the documentation standard for billable peer support services. Each participant's note must reflect that individual's engagement, response, and progress toward their own person-centered plan goals. This is more documentation work than individual services, but it is both a compliance requirement and a quality standard. It ensures that each person in the group receives individualized attention and that their progress is tracked meaningfully. When a group participant is not engaging, is disruptive, or is experiencing a crisis during a group session, the facilitator must respond in a way that protects all members. In some cases, a private conversation during a break or after the group is the appropriate response. In cases where a participant is in active crisis, the group may need to be paused and the crisis response protocol activated. The facilitator should debrief any such incidents with their supervisor and document what occurred and how it was addressed. Now let us discuss community resource navigation in greater depth, because this is an area where certified peer support specialists can make a uniquely powerful contribution. Many of the people served by PHSNC face practical barriers that directly affect their recovery. Housing instability, food insecurity, unemployment, lack of transportation, legal system involvement, and immigration challenges can all undermine even the most motivated person's ability to maintain recovery. Peer support that ignores these realities is incomplete. Effective resource navigation begins with the certified peer support specialist having current, accurate knowledge of available community resources. This knowledge does not come from a list compiled once and never updated. It comes from ongoing engagement with community organizations, attendance at community meetings, relationships with resource providers, and regular review of available services. Resource navigation also requires that the certified peer support specialist understand how to help a person access a resource successfully. This is more than providing a phone number. It may involve helping the person understand what to expect from the resource, practicing what they will say when they call, accompanying them to an initial appointment, helping them complete required forms, and following up to confirm that the connection was made. When a resource is not available or has a long wait list, the certified peer support specialist should document the referral attempt and the outcome and help the person identify alternative resources or interim supports. Advocacy at the system level through appropriate channels is also a legitimate part of the peer support role when community resources are inadequate to meet the needs of the people PHSN serves. Cultural and linguistic competence in resource navigation is also essential. A resource that is not accessible in the person's preferred language does does not respect their cultural practices, or has a history of discriminatory treatment is not truly available to that person. Certified peer support specialists should be honest with the people they serve about the limitations of available resources and should advocate for more equitable options when existing resources fall short. Let us now walk through a detailed discussion of the non-covered activity list and why each category exists. Understanding not just what is excluded, but why it is excluded, helps staff make better decisions in ambiguous situations. Transportation without a service component is not billable. Peer support, because driving a person from one place to another does not by itself build skills, strengthen recovery, or address documented clinical needs. The value of transportation in supporting access to services is recognized, but there are separate transportation benefit structures in NC Medicaid for that purpose. If a certified peer support specialist provides a skill-building intervention in the car, that may be billable if properly documented, but the billing begins at the point the structured intervention starts, not when they start driving. Module 4, Service Orders, Documentation, and Billing Integrity. Let us spend significant time on documentation because this is one of the areas where PHSNC staff must be strongest. Medicaid audits examine documentation first. A service that was delivered but poorly documented is a service that cannot be defended. A service that was well documented but not actually delivered is fraud. PHSNC expects documentation that is both truthful and complete. The service note is the primary documentation tool for peer support. Every service contact requires a note. There are no exceptions for short contacts, familiar beneficiaries, or routine visits. Every note must stand on its own. An auditor reading a single service note should be able to understand who was served, what service was provided, why it was provided, what happened during the contact, how long it lasted, how the person responded, whether progress occurred, and how the service connected to the person-centered plan. Let us walk through each required element in detail. The beneficiary name and Medicaid ID must appear on every note. This seems obvious, but missing identifiers are a common documentation deficiency that can result in claim denial. The date of service must match the date the service was actually rendered. Never document a service on a different date than it occurred. Backdating is a form of documentation fraud and is never acceptable. The service name and billing code must be accurate. For individual peer support, the code is H0038. For group peer support, the code is H0038HQ. The place of service code must also match the actual location where the service was rendered. The type of contact identifies whether the service was face-to-face, telehealth, or telephonic. This matters for billing modifiers and for confirming compliance with telehealth limits. The purpose of contact must clearly tie to a person-centered plan goal. This is the connection that justifies medical necessity. A note that says the purpose was to provide support is not sufficient. A note that says the purpose was to help the individual practice the coping strategies identified in Person-Centered Plan Goal 3 related to managing anxiety in social situations is much stronger. The intervention delivered is the heart of the note. This section must describe specifically what the certified peer support specialist did during the contact. Did they model a skill? Did they role-play a scenario? Did they help the person complete an application? Did they use peer coaching to help the person explore a decision? The intervention must be described in enough detail that a reader who was not present could understand what happened. Documentation is one of the most important responsibilities in peer support services. The note is not just a billing requirement. It is the record that shows what happened, why it happened, how it connected to the person-centered plan, how long it took, how the beneficiary responded, and whether progress occurred. Understanding the MCO billing process in depth is essential for certified peer support specialists, billing staff, and supervisors alike. A claim that is submitted correctly and supported by complete documentation is far more likely to be paid promptly and to survive audit scrutiny. A claim that is submitted with errors, missing information, or inadequate documentation creates administrative burden, delays payment, and may result in recoupment. NC Medicaid peer support services are billed using Healthcare Common Procedure Coding System codes, also known as HCPCS codes. The primary codes are H0038 for individual peer support, billed in 15-minute units, and H0038HQ for group peer support, also billed in 15-minute units. The place of service code must accurately reflect where the service was delivered. The date of service must match the service note. The diagnosis code must match the documented diagnosis in the clinical record. Timely filing is another billing requirement that PHSNC staff must understand. Most MCOs require that claims be submitted within a specified number of days following the date of service. The timely filing period varies by MCO and may be as short as 90 days or as long as 1 year. Claims submitted after the timely filing deadline will be denied, and there is generally no appeal pathway for timely filing denials. This makes prompt documentation and billing submission critical. When a claim is denied, the denial explanation must be reviewed carefully. Common denial reasons include missing or invalid service orders, eligibility issues, authorization problems, coding errors, duplicate claims, and timely filing violations. Each denial type has a different resolution pathway. Some denials can be corrected and resubmitted. Others require an appeal. Some cannot be recovered. PHSNC billing staff should track denials systematically, identify patterns, and work with supervisors to address root causes. Corrective action in response to billing errors is an important compliance activity. When a claim is paid incorrectly, whether due to overbilling or underbilling, PHSNC has a responsibility to address it. Overpayments must be reported and refunded. Underpayments may be addressed through appeals or adjusted claims. PHSNC staff should never ignore a billing error in the hope that it will go unnoticed. Voluntary disclosure and correction of billing errors is treated more favorably by oversight agencies than errors discovered through audit. Let us also discuss the relationship between documentation and the revenue cycle. At PHSNC, documentation is not just a clinical responsibility, it is also a financial one. When documentation is incomplete, services cannot be billed. When documentation is inadequate, claims are denied or recouped. When documentation is excellent, services are paid correctly and audits can be defended. The quality of documentation has a direct and significant impact on PHSNC's ability to generate the revenue needed to sustain the mission. Certified peer support specialists who understand this connection take documentation seriously, not only because it is required, but because it enables PHSNC to continue serving the community. Every well-written note is a contribution to the organization's sustainability. Every vague, incomplete, or missing note is a cost that is ultimately borne by the people PHSNC serves. Let us now walk through several billing scenarios to test your understanding. Scenario 1. A certified peer support specialist provides a 60-minute individual peer support session on a Tuesday. The service was delivered in the community. The contact was face-to-face. How many units should be billed? 4 units of H0038, using the appropriate place of service code for community with no telehealth modifier. 4 units multiplied by 15 minutes equals 60 minutes, matching the documented duration. Scenario 2. A certified peer support specialist facilitates a group session with 8 participants for 45 minutes. How many units should be billed per participant? 3 units of H0038 HQ per participant. The HQ modifier indicates group. 3 units multiplied by 15 minutes equals 45 minutes. Each participant's claim must be supported by an individual service note. Scenario 3. A certified peer support specialist provides a 30-minute telephonic session with a beneficiary who does not have video access. Which billing code and modifier should be used? H0038KX. The KX modifier indicates telephonic audio-only service. 2 units should be billed, supported by a note confirming consent was documented. 2 identifiers were verified, and the intervention connected to a person-centered plan goal. Audit readiness is not something that happens when an audit is announced. Audit readiness is a daily practice. At PHSNC, we expect every service note to be written as if an auditor will read it tomorrow. This standard protects both the beneficiary and the organization. When NC Medicaid or a managed care organization conducts a review of peer support services, they typically examine a sample of service records. These records include the clinical assessment, the person-centered plan, service orders, service notes, and billing records. Auditors are looking for evidence that each service was medically necessary, properly authorized, delivered by a qualified provider, and accurately documented and billed. A common audit finding is the absence of a valid service order at the time services were provided. This results in recoupment of payments for all services rendered without the order. The recoupment applies even if the services were clinically appropriate and well documented in every other respect. The service order requirement is strict and absolute. Another common finding is documentation that does not support the number of units billed. If a note describes a 30-minute contact but 4 units were billed, the auditor will recoup 2 units. If a note describes a 2-hour contact that began after the beneficiary arrived 20 minutes late and ended before a planned activity was completed, the billable time must reflect the actual time spent in covered intervention, not the scheduled duration. Auditors also look for patterns of documentation that suggest cloning, plagiarism, or fabrication. If multiple notes for the same beneficiary or multiple beneficiaries use identical language, this raises a red flag. Each note must reflect what actually happened on the specific date of service for the specific individual. Variations in language, setting, activity, and response are expected and reassuring to auditors because they reflect authentic documentation. Record retention is another compliance requirement that PHSNC staff must understand. NC Medicaid requires that clinical and billing records be retained for a minimum of 10 years. This includes service notes, assessment documents, person-centered plans, service orders, consent forms, eligibility verification records, and billing documentation. Records must be maintained in a secure, confidential manner and must be accessible for audit review upon request. PHSNC has specific record retention policies that staff must follow. When a beneficiary leaves the program, their records must be retained according to the retention schedule, even after services end. Records may not be destroyed before the retention period expires, even if the organization undergoes transitions, changes in ownership, or technology upgrades. Staff must know where records are stored and how to retrieve them in a timely manner. Electronic records present specific compliance considerations. Electronic health records must be backed up regularly, protected from unauthorized access, and auditable for any changes made after the initial entry. Corrections to electronic records should be made using the system's official correction process, which typically creates a clear audit trail showing what was changed, when, and by whom. Staff should never delete or overwrite original documentation. Let us also address the role of internal audits in PHSNC's compliance program. PHSNC conducts internal documentation reviews as a quality assurance activity. These reviews are not punitive. They are designed to identify training needs, documentation gaps, and systemic issues before they become external audit findings. Staff who receive feedback from an internal review should use it as a learning opportunity and work with their supervisor to improve their documentation practices. When an external audit does occur, PHSNC staff should cooperate fully, provide requested records promptly, and communicate openly with their supervisor and the compliance team. Staff should not attempt to add, alter, or backdated documentation in response to an audit request. Any such alteration would transform a documentation deficiency into a fraud allegation, which carries much more serious consequences. Service orders are a topic that deserves more detailed attention. A service order is a clinical authorization document that must be signed by a physician, physician assistant, nurse practitioner, or other licensed clinician authorized to issue orders under NC Medicaid rules. The service order authorizes the provision of peer support services for a specific beneficiary during a defined time period. The The service order must be signed before or on the first date of service. If a new service order is needed because the prior one has expired, the renewal must be signed before services continue. There is no grace period. Providing and billing services after a service order has expired, even by 1 day, is a compliance violation. The service order should reflect the clinical basis for the service, including the diagnosis and the clinical rationale for peer support. It should be consistent with the person-centered plan and the assessment. An order that simply says provide peer support without any clinical context is weaker than an order that references the specific diagnosis, clinical need, and connection to recovery goals. Retroactive Medicaid eligibility is a concept that sometimes causes confusion. If a person is enrolled in Medicaid retroactively, covering a period before their enrollment was processed, that retroactive eligibility does not eliminate the need for a valid service order for that period. Services must have been properly ordered at the time they were provided. Retroactive eligibility restores the payer source, but it does not retroactively authorize services that were provided without an order. PHSNC staff must maintain a tracking system for service orders that includes the start and end date of each order for each beneficiary, the name of the ordering clinician, and the renewal timeline. Supervisors should review this tracking regularly to ensure that no beneficiary is receiving services under an expired or missing order. A valid service order must be signed before or on the first day the service is rendered. Retroactive Medicaid eligibility does not remove the requirement for a valid service order. Staff must not bill services that are not properly ordered, medically necessary, delivered, and documented. Each service note must include the beneficiary's name, Medicaid ID, date of service, name of service, type of contact, place of service, purpose of contact, intervention provided, duration, effectiveness, progress toward goals, staff signature, date, and credentials or job title. Duration must be recorded accurately and must match the number of units billed. 1 unit of H0038 equals 15 minutes. If a contact lasted 45 minutes, 3 units may be billed, but only if the full 45 minutes was spent in a covered intervention. Time spent driving to the location, waiting for the person to arrive, or managing unrelated conversations does not count toward billable time. The Response and Effectiveness section documents how the beneficiary participated and responded. Did they engage willingly? Did they practice the skill successfully? Did they express ambivalence? Did they make progress? Did they encounter a barrier? This section makes the note clinically meaningful. It shows that the service was not just delivered, but that the delivery mattered. Progress toward the goal completes the clinical picture. Notes should show movement over time. Not every contact will result in dramatic progress, but the notes across a month or a quarter should tell a story of movement toward the person-centered plan goals. If a series of notes shows no movement and no explanation for why progress has stalled, this is a quality assurance concern that a supervisor should address. The signature, date, and credentials of the staff member who delivered the service must appear on every note. The person signing the note must be the person who delivered the service. A supervisor should not sign a note for a service they did not deliver. Now let us discuss common documentation errors and how to avoid them. The most frequent audit finding in peer support documentation is vagueness. Phrases like provided support, checked in, offered encouragement, and worked on goals tell an auditor almost nothing. These phrases do not demonstrate a covered intervention. They suggest that the certified peer support specialist may not have had a structured purpose for the contact. PHSNC expects notes that describe the actual work, not placeholders. Another common error is copying and pasting content from previous notes without updating the details. This practice, sometimes called cloning, creates documentation that does not reflect what actually happened on a given date. It is a compliance violation and can result in recoupment of payments. A third common error is documenting services that span longer than the actual contact without adjusting the units billed accordingly. If a contact was scheduled for an hour but ended after 30 minutes, only 2 units should be billed, not 4. Billing units that are not supported by the documented duration is overbilling, which is a serious compliance violation. At PHSNC, supervisors are expected to review service notes regularly, provide corrective feedback when documentation does not meet standards, and escalate persistent documentation problems through the quality assurance process. Staff who consistently produce vague, incomplete, or inaccurate documentation should receive targeted coaching and support before the problem results in a compliance finding. The staff member who provides the service is responsible for documenting the billed service. At PHSNC, documentation should be clear, timely, truthful, person-centered, and audit-ready. Strong peer support notes describe what the certified peer support specialist did, what skill was practiced, how the person responded, and how the intervention supported the person-centered plan goal. Avoid vague phrases like checked in, hung out, provided support, or client was non-compliant. These statements do not clearly show a covered intervention, progress, or medical necessity. Instead, use objective recovery-focused language. Describe the skill, the barrier, the intervention, the person's participation, and the next step. Here's an example of a weak note. Met with client and provided support. Here's an example of a strong note. The certified peer support specialist met with the beneficiary in the community to practice budgeting skills connected to person-centered plan goal 2. The specialist modeled how to compare prices, use a written list, and identify anxiety triggers during shopping. The beneficiary participated, selected lower-cost items, and reported feeling more confident using the strategy independently. Billing unit integrity matters. H0038 equals one 15-minute unit for individual peer support. H0038 HQ equals one 15-minute unit for group peer support. Documentation must support the number of units billed. The duration must be credible and consistent with the intervention described. Staff must never document or bill transportation time, waiting time, unplanned recreation, supervision, or services not actually rendered. Effective performance management begins with clear expectations. Every certified peer support specialist at PHSNC should know what is expected of them in terms of documentation quality, service delivery standards, caseload management, supervision participation, professional boundaries, and Medicaid compliance. These expectations should be communicated clearly during onboarding, reinforced in supervision, and reviewed during formal performance evaluations. Performance evaluations for certified peer support specialists should include review of documentation quality, caseload management, professional conduct, adherence to scope of practice, participation in supervision and training, and outcomes for the people they serve. Evaluations should be strengths-based, identifying areas of strong performance as well as areas for development. A performance evaluation that only lists deficiencies without acknowledging strengths is not consistent with PHSNC values. When a performance concern arises, the supervisor should address it promptly and directly. Letting a concern fester without addressing it is not kindness. It is a disservice to the staff member, the people they serve, and the organization. The conversation should be respectful, specific, and focused on behavior and performance rather than personal characteristics. The supervisor should listen to the staff member's perspective, explore any contributing factors, and work collaboratively to develop a corrective action plan. A corrective action plan should identify the specific performance concern, the expected standard, the steps the staff member will take to meet that standard, the support the organization will provide, and the timeline for review. Progress against the plan should be monitored actively and documented. If the staff member meets the expectations of the plan should be closed with acknowledgement of the improvement. If progress is not made, the organization must take further action consistent with PHSNC's human resources policies. Workforce culture in a peer support program is shaped by every interaction, every decision, and every message from leadership. A culture that values recovery, respects lived experience, supports staff well-being, and holds people accountable with compassion is a culture that attracts and retains strong certified peer support specialists. A culture that treats staff as problems to be managed rather than people to be developed will struggle with high turnover, low morale, and declining quality. PHSNC leaders at every level have a responsibility to model the culture they want to create. When a supervisor arrives to a supervision meeting prepared, present, and engaged, they demonstrate that the specialist's work matters. When a supervisor responds to a mistake with curiosity instead of punishment, they model the non-judgmental approach they expect the specialist to use with beneficiaries. When a supervisor advocates for reasonable caseloads and adequate training time, they demonstrate that staff well-being is a priority, not an afterthought. Now let us discuss quality assurance in more depth. Quality assurance is the systematic process of monitoring and evaluating service delivery to ensure that it meets established standards and that improvement opportunities are identified and acted upon. At PHSNC, quality assurance is not a separate department's job. It is everyone's responsibility. At the individual level, quality assurance means that every certified peer support specialist reviews their own documentation before submitting it to ensure it is complete, accurate, and audit-ready. It means that every specialist monitors their own performance, seeks feedback proactively, and brings concerns to supervision before they become problems. At the supervisor level, quality assurance means conducting regular documentation reviews for every staff member on the team, providing specific and actionable feedback, tracking trends across the team, and communicating quality concerns to organizational leadership. Supervisors should conduct at minimum monthly documentation reviews and should increase the frequency for staff who are new, who have received corrective feedback, or who are carrying complex caseloads. At the organizational level, quality assurance means that PHSNC has a formal program for monitoring outcomes, tracking billing accuracy, reviewing incident reports, analyzing grievances and appeals, and responding to identified quality concerns with systemic improvements. The quality assurance program should produce regular reports that are reviewed by leadership and used to drive continuous improvement in service delivery. Quality assurance activities must be documented. Documentation of quality assurance activities, including supervision logs, documentation review records, corrective action plans, and quality improvement reports, may be requested during external audits and licensing surveys. PHSNC supervisors must maintain these records in an organized and accessible manner. Caseload management is a practical and clinical responsibility that directly affects quality of care. Policy 8G establishes maximum ratios, but effective caseload management requires supervisors and specialists to think beyond the numbers. A certified peer support specialist with 15 beneficiaries on their caseload may be managing a very different workload than another specialist who also has 15 beneficiaries. Some beneficiaries require frequent contact, intensive skill building, complex resource navigation, or heightened attention due to crisis risk. Others may be further along in their recovery and require less intensive support. Supervisors should assess caseload intensity, not just caseload size, when assigning cases and evaluating workload. When a certified peer support specialist is carrying a caseload that is too large or too complex for them to serve effectively, quality and compliance suffer. Notes become rushed and vague. Service contacts become less structured. Progress stalls. Supervisors must be willing to adjust caseloads when necessary, even when it creates operational challenges, because quality and compliance are non-negotiable at PHSNC. Caseload management also includes maintaining active current case lists and ensuring that no beneficiary is receiving services without all required documentation in place. Each certified peer support specialist should be able to produce, for any active beneficiary on their caseload, the current eligibility verification, the valid service order, the current person-centered plan, and the most recent service notes at any time. If any of these documents is missing, the supervisor must be informed immediately. When a beneficiary needs to be transitioned from one certified peer support specialist to another, the transition must be managed carefully. Abrupt transitions can be destabilizing for people in recovery who have built trust with their specialist. Transitions should be planned with adequate time for a warm handoff, which means the outgoing and incoming specialists ideally meet with the beneficiary together and ensure continuity of the relationship and the recovery plan. Now let us address the ethics of working with people who are experiencing significant mental health challenges or active substance use. Certified peer support specialists will sometimes serve people who are ambivalent about recovery, who relapse, who disengage from services, or who behave in ways that are difficult or frustrating. How a specialist responds in these moments matters deeply. Ambivalence is normal in recovery. People who have struggled for years do not typically embrace change easily or consistently. The certified peer support specialist should respond to ambivalence with curiosity and patience, not judgment or pressure. Motivational approaches that explore the person's own reasons for change, acknowledge the difficulty of that change, and affirm the person's autonomy are more effective and more ethical than confrontational or coercive responses. Relapse is part of many people's recovery journeys. A relapse does not mean failure. It does not mean services should be terminated. It does not mean the person is hopeless. It means the person needs support to understand what happened, adjust their recovery plan, and re-engage with their goals. The certified peer support specialist's response to a relapse should be compassionate, non-judgmental, and recovery-focused. At the same time, if the relapse involves behavior that creates safety risks, the specialist must communicate with their supervisor and follow PHSNC safety protocols. When a beneficiary disengages from services, the certified peer support specialist and supervisor should attempt reasonable outreach before closing the case. The outreach attempts should be documented. If the person cannot be reached after appropriate outreach, the case may need to be closed, but the documentation must reflect the outreach attempts and the clinical reasoning for the closure. A person who disengages should always be welcomed back when they are ready to re-engage. Finally, let us talk about the certified peer support specialist as a model of recovery within the community. When a specialist shows up consistently, follows through on commitments, treats people with dignity, maintains professional boundaries, and demonstrates genuine care, they are not just delivering a service. They are living proof that recovery is possible and that meaningful work in the service of others is one of the most powerful expressions of a life in recovery. Let us explore the staffing requirements in greater depth, because understanding who can provide and supervise peer support services is critical for both compliance and quality. The certified peer support specialist is the cornerstone of peer support delivery. To obtain certification through North Carolina's Peer Support Specialist Program, a person must self-identify as someone with lived experience of mental health challenges or substance use disorder. They must complete the required training curriculum, pass the certification examination, and maintain their certification through continuing education. The certification belongs to the individual, not to the organization. If a certified peer support specialist leaves PHSNC, their certification goes with them, and PHSNC must ensure that the services are reassigned to another certified staff member. The certified peer support specialist must adhere to the North Carolina Peer Support Specialist Code of Ethics. This code addresses boundaries, confidentiality, appropriate use of lived experience, non-judgmental practice, cultural responsiveness, and other professional standards. A certified peer support specialist who violates the Code of Ethics may face consequences, including loss of certification. PHSNC supervisors must know the Code of Ethics and must ensure that their team members practice in accordance with it. The qualified professional who directs the peer support program must be full-time. This is not a role that can be split across multiple part-time functions. The qualified professional is responsible for overall program oversight, assessment coordination, person-centered plan collaboration, quality assurance, and staff supervision. In NC Medicaid, a qualified professional for behavioral health services typically holds a graduate degree in a human services field and has appropriate licensure or credentials as defined by the relevant service definitions. Competent mental health or substance use professionals must provide supervision to the certified peer support specialists during service provision. The word competent here is important. A supervisor who does not understand recovery philosophy, the peer support role, or the Medicaid policy governing these services is not competent to supervise them, regardless of their professional credentials. PHSNC invests in training supervisors so that they can provide the kind of supervision that improves practice, prevents errors, and supports the development of each certified peer support specialist on their team. Peer support services must be delivered by practitioners employed by qualified organizations. The organization must meet NC Medicaid provider qualifications, state rules, credentialing requirements, contracting requirements, and accreditation requirements. Peer support services must be provided by a peer support specialist certified by North Carolina's Peer Support Specialist Program. The program must be directed by a full-time qualified professional. Competent mental health or substance use professionals must provide supervision during service provision. Peer support must be available during times that meet beneficiary needs, including evenings and weekends when necessary. Supervision is not just an administrative requirement, it is a clinical and ethical necessity. Effective supervision in peer support includes 4 components. First, administrative supervision addresses scheduling, documentation, billing, caseload management, and compliance with policies and procedures. Second, supportive supervision addresses the emotional and personal dimensions of peer support work. Certified peer support specialists regularly encounter people in significant distress. They may hear stories that resonate with their own lived experience. They may feel uncertain about a situation. Supportive supervision provides a safe space to process these experiences, maintain professional boundaries, and prevent burnout. Third, reflective supervision encourages the certified peer support specialist to examine their own practice, identify areas for growth, and deepen their understanding of recovery-oriented principles. Fourth, competency-based supervision focuses on skill development, including documentation quality, intervention effectiveness, and adherence to ethical standards. Supervisors at PHSNC should provide a minimum of 1 individual supervision session per month for each certified peer support specialist. Supervisors may need to provide more frequent supervision for new staff who are serving individuals with complex needs, or staff who have received corrective feedback on documentation or practice issues. Group supervision is a valuable supplement to individual supervision. It allows certified peer support specialists to share experiences, learn from each other, problem solve together, and build a sense of team. However, group supervision cannot replace individual supervision. Supervisors must maintain individual supervision even when group supervision is happening regularly. Let us also address scope of practice in more detail, because this is where many errors occur. A certified peer support specialist may not diagnose. They may not prescribe or recommend medications. They may not provide psychotherapy or clinical counseling. They may not make promises about outcomes. They may not share another person's information without consent, even with a family member. They may not form personal relationships outside the professional context. They may not accept gifts of significant value. They may not provide services at times or in places that are not authorized by the service plan and PHSNC procedures. When a certified peer support specialist encounters a situation that is outside their scope, the correct response is always to consult their supervisor before acting. This is not a sign of incompetence. It is a sign of professionalism, and it protects. Program supervisors carry significant responsibility. They must understand recovery philosophy, the Certified Peer Support Specialist role, and the North Carolina Certified Peer Support Specialist Code of Ethics. They coordinate assessments, collaborate on person-centered plans, Contact the beneficiary within 90 days of peer support services initiation and at least every 90 days thereafter. Review notes, evaluate work, ensure quality assurance, and provide individual administrative and supportive supervision at least monthly or more often when needed. Certified peer support specialists must demonstrate core competencies. These include ethical peer practice, appropriate use of lived experience, helping individuals explore barriers, supporting navigation of systems, modeling recovery, promoting self-advocacy, and responding appropriately to physical or behavioral health crises according to employer procedures. Let us now discuss the hiring, onboarding, and ongoing development of certified peer support specialists in more detail, because this is where the quality of peer support begins. Hiring a certified peer support specialist requires careful screening. The right candidate has not only certification, but also the maturity to use their lived experience professionally, the communication skills to build trust and deliver structured interventions, the boundary awareness to maintain a professional relationship, and the resilience to work in a field that is emotionally demanding. PHSNC supervisors should use structured interview questions that assess these qualities, and they should check references carefully. Onboarding should be comprehensive. A new certified peer support specialist should receive orientation to PHSNC's mission, values, policies, and procedures before they serve any beneficiary independently. They should receive specific training on the documentation system, billing codes, service order requirements, and quality standards. They should be paired with an experienced supervisor or mentor who can guide their early practice. Within 30 days of hire, all staff must complete at minimum 3 hours of peer support policy review and 1 hour of documentation training. This training should not be a passive review of written materials. It should be interactive, covering real scenarios, answering real questions, and ensuring that the staff member understands not just the rules, but the reasoning behind them. Within 90 days, supervisors must complete a specific set of trainings that are identified in Policy 8G. These include peer support supervisor training, person-centered thinking training, and training on person-centered plan development with crisis planning elements. These trainings equip supervisors to lead a person-centered program, not just manage compliance. Annual continuing education requirements ensure that all staff stay current with evolving policy, best practices, and professional standards. 10 hours of continuing education per year may seem modest, but it represents a meaningful commitment to ongoing learning when it is combined with regular supervision, case consultation, and performance feedback. Systems advocacy is the final frontier of the peer support role, and it is one of the most powerful expressions of the PHSNC value of advocacy. Individual advocacy helps one person navigate one system. Systems advocacy challenges the systems themselves to become more equitable, accessible, and effective for everyone. Certified peer support specialists are uniquely positioned to contribute to systems advocacy because they experience both the lived reality of the people being served and the professional context of the services being delivered. They see what works and what does not. They hear from the people they serve about what the system gets wrong. They notice when policies create barriers instead of removing them. This vantage point is a resource, and PHSNC believes in harnessing it responsibly. Systems advocacy within the scope of peer support means supporting beneficiaries in using their own voices to engage with systems that affect their lives. It means helping a person prepare to speak at a public hearing about housing policy. It means supporting a person in writing a letter to their state representative about mental health funding. It means connecting a person to peer-run advocacy organizations where they can join with others to call for change. The certified peer support specialist facilitates and supports this advocacy. They do not substitute their own voice for the person's. At the organizational level, PHSNC engages in systems advocacy by participating in stakeholder processes, providing input on policy development, sharing outcome data with policymakers, and collaborating with other providers and consumer organizations to advocate for equitable behavioral health services. Staff are encouraged to stay informed about policy developments that affect the people they serve and to share their observations with leadership through appropriate channels. Disparity reduction is both a quality imperative and a justice commitment at PHSNC. Research consistently documents that people of color, people with low incomes, people who are LGBTQ+, people in rural areas, and people with limited English proficiency experience significant disparities in access to behavioral health services and in outcomes. These disparities are not inevitable. They are the product of systemic barriers that can be identified, measured, and reduced. At PHSNC, disparity reduction means actively examining whether services are reaching all segments of the community equitably, whether outcomes differ across demographic groups, whether staff reflect the cultural and linguistic diversity of the people they serve, and whether the organization's policies and practices create barriers for any group. Certified peer support specialists contribute to disparity reduction by serving people with cultural humility, providing or connecting people to culturally specific resources, advocating for translation and interpretation services when needed, and speaking up when they observe practices that may be inequitable. Supervisors contribute by ensuring that caseloads reflect diversity, that staff receive culturally competent supervision, and that feedback from underserved communities is actively sought and acted upon. Let us close this comprehensive training with a final review of the most important principles and commitments that define peer support practice at PHSNC. Medical necessity must be documented clearly and specifically, not assumed or generalized. The golden thread must connect every assessment, plan, order, service, and note. Documentation must be complete, timely, truthful, and audit-ready from the moment it is written. Billing must reflect only services actually delivered for the actual duration using the correct codes and modifiers. Scope of practice must be respected and maintained at all times. Supervision must be sought whenever there is uncertainty, ambiguity, or concern. And through all of this compliance and clinical rigor, the most important thing remains the person. The person who has the courage to seek recovery. The person who trusts PHSNC and their certified peer support specialist to walk alongside them. The person whose dreams deserve to be honored with our very best work every single day. At PHSNC, we hold the belief that every person we serve is capable of recovery, growth, and a meaningful life. We hold the commitment that every service we provide will reflect that belief. We hold the standard that compliance is the floor and mission is the ceiling. And we hold the hero statement not as a slogan on a wall, but as a living promise, helping you live your dreams every day. Thank you for your time, your attention, and your commitment to this work. You are the reason PHSNC's mission is possible. Quality improvement in peer support services is not a reactive process triggered by audits or complaints. It is a proactive, continuous commitment to delivering better care and better outcomes for every person PHSNC serves. A quality improvement culture begins with leadership. When supervisors model reflective practice, welcome feedback, respond constructively to errors, and celebrate growth, they create a team environment where quality is everyone's priority. When supervisors respond to mistakes with punishment alone, without exploration, learning, or corrective support, they create a culture of fear that suppresses honest reporting and makes quality problems worse. At PHSNC, quality improvement activities include regular documentation reviews, individual supervision that includes case consultation, team meetings where challenging cases are discussed anonymously, outcome data review, and beneficiary satisfaction feedback. Each of these activities generates information that can be used to improve practice. When a quality improvement review identifies a pattern of documentation deficiency, the response should begin with a training intervention. Is the problem due to a lack of knowledge, a workload issue, a technology barrier, a misunderstanding of expectations? The corrective response should match the root cause. A staff member who does not understand what a strong note looks like needs training and examples. A staff member who understands but does not have enough time to document properly may need caseload adjustment or workflow support. Beneficiary feedback is one of the most valuable and underutilized quality improvement tools in behavioral health services. When people receiving peer support are asked directly about their experience, what is working, what is not, what they wish were different. They provide information that no documentation review can capture. PHSNC encourages regular, structured feedback from beneficiaries and commits to using that feedback to improve services. Let us now walk through a comprehensive, extended case scenario that brings together everything covered in this training. Meet Darnell. Darnell is a 32-year-old man with a diagnosis of bipolar disorder and alcohol use disorder, meeting ASAM Level 1 criteria. He has been hospitalized twice in the past year and is currently living with his sister while looking for his own apartment. He is motivated to stay in recovery, but struggles with social anxiety, difficulty managing daily stress, and limited confidence in his ability to live independently. Darnell's person-centered plan includes 3 peer support goals. Goal 1. Darnell will practice 2 coping strategies for managing stress and alcohol cravings, with weekly support from his certified peer support specialist over the next 90 days. Goal 2. Darnell will identify and access 2 community resources to support his housing search, with support from his certified peer support specialist within 60 days. Goal 3. Darnell will practice daily living skills, including budgeting, grocery shopping, and meal planning, with support from his certified peer support specialist as he prepares for independent living. The certified peer support specialist assigned to Darnell uses each service contact to address one or more of these goals. In one session, they role-play how Darnell will talk to a housing program case manager about his eligibility. In another, they practice the coping strategy of progressive muscle relaxation that Darnell learned in therapy. In another, they visit a community resource center together and help Darnell complete an application for a rental assistance program. Each contact is structured, goal-connected, and documented with specificity. Over 90 days, Darnell's notes show consistent progress. He is using his coping strategies more reliably. He has connected with 2 housing resources and is on a wait list for an affordable unit. He has practiced grocery budgeting 3 times. He reports greater confidence in his ability to manage daily life independently. The certified peer support specialist documentation tells this story clearly and compellingly. This is what excellent peer support practice looks like at PHSNC. This is what helping you live your dreams every day means in action. Outcomes in peer support are measured at multiple levels. At the individual level, outcomes are measured by tracking progress toward person-centered plan goals. Is the person closer to their stated goals than they were at intake? Are they using more community resources? Are they managing their symptoms more effectively? Are they participating in more activities? Are they reporting greater confidence and self-efficacy? At the program level, PHSNC tracks aggregate outcomes across the peer support program to identify trends, address disparities, and improve service delivery. If a pattern of stalled progress appears across multiple beneficiaries, this may indicate a training need, a supervision gap, a caseload problem, or a resource access barrier that requires a systemic response. At the Medicaid level, outcomes are tied to the managed care organization's quality metrics and the state's behavioral health priorities. PHSNC participates in quality reporting that demonstrates the value and effectiveness of peer support services to payers and oversight bodies. For certified peer support specialists, outcomes measurement begins with good documentation. Every service note that clearly records the purpose of the contact, the intervention delivered, the person's response, and progress toward goals is a data point in the outcomes story. When notes are vague, outcomes cannot be measured. When notes are clear and complete, outcomes can be tracked, reported, and improved. Let us also address what happens when outcomes are not being achieved. If a beneficiary is not making progress toward their person-centered plan goals after a reasonable period of service, the team must reassess. This is not a failure of the person. It is a signal that something in the service plan needs to change. Perhaps the goals need to be adjusted. Perhaps the intervention strategies need to change. Perhaps additional clinical support is needed. Perhaps the person is facing practical barriers that are interfering with their engagement. The response to lack of progress should be thoughtful, collaborative, and documented. The purpose of peer support is not only service delivery, It is measurable recovery impact. Expected outcomes include increased engagement in self-directed recovery, increased natural and social supports, increased community involvement, increased ability to live independently, improved emotional, behavioral, and physical health, improved quality of life, and decreased substance use, crisis episodes, crisis services, or hospitalizations. At PHSNC, we connect these outcomes to our values. Purpose means the service has a clear reason. Heart means the person experiences dignity and respect. Impact means we can see progress. Leadership means staff follow policy and model accountability. Advocacy means the person gains voice, access, and confidence. Compliance at PHSNC is understood as a shared responsibility, a professional obligation, and a mission commitment. When services are billed correctly, resources remain available for the people who need them. When services are billed incorrectly, the consequences extend beyond financial recoupment. They can include exclusion from Medicaid participation, loss of organizational credibility, staff termination, and most importantly, harm to the people we serve. Let us walk through the most common compliance risk areas and how PHSNC's staff can address each one. Missing or late service orders are one of the most preventable compliance risks. A service order must be signed before or on the first date of service. PHSNC staff should have a system for tracking service order status for every active beneficiary. If a service order is expiring, the staff member should initiate the renewal process at least 2 weeks in advance. Never provide a service without confirming that a valid, signed service order is on file. Notes not tied to person-centered plan goals represent a documentation and clinical compliance gap. Every note must explicitly reference the person-centered plan goal that the service contact addressed. This is not a formality. It is the clinical and compliance justification for the service. Billing transportation, or waiting time, is a recurring issue. The certified peer support specialist's travel time to and from a service location is not billable. Waiting for a beneficiary who is late is not billable. Only the time spent in actual covered intervention is billable. Duplicate services occur when the same service is billed by 2 different providers on the same date for the same beneficiary, or when peer support is billed at the same time as another service that cannot be provided simultaneously. PHSNC staff must confirm that their services do not overlap with other covered services on the same date and time. Telehealth compliance failures include billing telehealth without documented consent, failing to verify 2 identifiers, exceeding the 20% annual limit, or using the wrong billing modifier. These are entirely preventable with proper training and consistent practice. At PHSNC, we take compliance seriously, not because we fear audits, but because compliance is how we protect the people we serve. Every time a PHSNC staff member provides a service correctly, documents it accurately, and bills it appropriately, they are demonstrating purpose, heart, impact, leadership, and advocacy in action. Compliance is everyone's responsibility. Staff must comply with applicable agreements, laws, regulations, HIPAA, record retention requirements, NC Medicaid policies, provider manuals, implementation updates, bulletins, managed care organization-specific requirements, and PHSNC procedures. When there is uncertainty, staff must ask for supervision before providing, documenting, or billing the service. Common audit risk areas include missing or late service orders, notes not tied to person-centered plan goals, vague interventions, billing transportation or waiting time, duplicating services, overlapping excluded services, telehealth without proper consent or safeguards, and time billed that is not supported by documentation. Let us close this training with a reflection on what it means to serve with purpose, heart, impact, leadership, and advocacy every day at PHSNC. Purpose means that every service you provide has a clear reason rooted in clinical need, person-centered plan goals, and the person's own recovery priorities. Purpose keeps us from drifting into unstructured or undocumented contacts that do not serve the person or protect PHSNC. When you sit down to document a service, ask yourself, what was the purpose of this contact? If you cannot answer that clearly, the contact may not have been as purposeful as it needed to be. Let that reflection guide your next service. Heart means that every interaction is infused with dignity, compassion, and cultural humility. The people we serve have often experienced significant loss, trauma, stigma, and systemic failure. They are not defined by their diagnoses or their histories. They are whole people with strengths, dreams, relationships, and potential. Heart means we see that wholeness and reflect it back to the people we serve. Impact means that we measure and demonstrate the difference our services make. Impact is not measured by the number of contacts we deliver. It is measured by whether the person is more capable, more connected, more confident, and more stable because of the peer support they received from PHSNC. Impact requires good documentation, meaningful goals, honest progress tracking, and a willingness to adjust when services are not working. Leadership means that every PHSNC staff member, regardless of title, is accountable for modeling recovery, following policy, supporting colleagues, and speaking up when something is not right. Leadership and peer support means being someone the person you serve can look to as evidence that recovery is real and that a life of purpose is possible. Advocacy means that we help the people we serve find and use their voice. It means helping them understand their rights, navigate systems, and access resources without creating dependency. It means standing alongside them, not in front of them. And sometimes when systems are failing the people we serve, advocacy means speaking up in appropriate ways to call for change. These values are not aspirational, they are operational. They show up in every service note, every supervision conversation, every team meeting, and every interaction with a person who trusts PHSNC to help them live their dreams. Helping you live your dreams every day. That is not just a slogan, it is a standard, and it is the standard to which every PHSNC staff member is called. Now review the following scenarios and decide whether each is billable peer support. Scenario 1. A certified peer support specialist drives a beneficiary to an appointment and waits outside. No skill building or recovery intervention is documented. This is not billable peer support. Scenario 2. A certified peer support specialist helps the beneficiary prepare for an appointment by practicing self-advocacy questions, identifying anxiety triggers, and reviewing how to communicate needs to the provider. This may be billable if connected to a person-centered plan goal and documented properly. Scenario 3. A certified peer support specialist provides a telephonic session, verifies 2 identifiers, documents consent, connects the intervention to a person-centered plan goal, and documents the beneficiary's response and progress. This may be billable if all policy requirements and limits are met. Scenario 4. A certified peer support specialist provides peer support at the same time the beneficiary is participating in another covered service. This is not billable as overlapping or duplicative service time. Use this 5-step compliance decision pathway before billing any service. Step 1. Is the person eligible? Step 2. Is medical necessity documented? Step 3. Is the service order valid? Step 4. Is the activity covered and non-duplicative? Step 5. Is the note complete and audit ready? Staff action commitments. As PHSNC staff, we commit to delivering peer support with integrity, compassion, and accountability. We will verify eligibility and required clinical documents before service delivery. We will connect every intervention to person-centered plan goals and documented recovery needs. We will stay within certified peer support specialist scope and avoid non-covered activities. We will document every required service note element clearly and timely. We will consult supervision whenever a service note or billing situation is unclear, and we will demonstrate purpose, heart, impact, leadership, and advocacy in every interaction and every note. Post-test instructions. This concludes the PHSNC Peer Support Services training on NC Medicaid Clinical Coverage Policy 8G. Staff should now complete the comprehensive post-test independently. A passing score of 80% or higher is recommended. Any missed items should be reviewed with a supervisor before providing or supervising peer support services. Completed post-tests and training documentation should be maintained in the staff training file. Thank you for your commitment to Medicaid-compliant, person-centered, recovery-oriented peer support services. At PHSNC, every service should help the people we serve move toward dignity, stability, recovery, community connection, and their dreams. Helping you live your dreams every day. This training is based on NC Medicaid Clinical Coverage Policy 8G and PHSNC internal training standards. Staff must follow the current NC Medicaid Policy, PHP, and PIHP guidance, applicable laws and regulations, and PHSNC procedures in effect on the date of service.